As we jump into Chapter 6, we're going to move forward with the injury evaluation process. We previously talked extensively about emergency care and how to do a primary assessment. The primary assessment is the first step that you take to care for the athletes. We need to be able to perform a primary survey or assessment in order to obtain advanced emergency medical care if needed. Now, in this next section, we are going to look at the secondary survey. Once we have ascertained that the athlete has no apparent life-threatening situations, that they're conscious, that they're not going into shock, or that you do not have to activate EMS for any reasons, we can move on to what is otherwise known as the secondary survey, or providing a basic injury examination. From there, we will care for the injury with whatever we find. The basic injury examination is a step-by-step, organized process that helps you determine the non-life-threatening conditions. This helps us determine what the actual specific injury and illness is, appropriate care that we need to do to care for that injury or illness, and whether we need to refer, not an emergency referral, but whether we need to refer to a physician or to another specialist from there on. So let's look at this basic injury examination. When we look at the basic injury examination, we're first going to start with identifying different aspects of the injury. The acronym that is used to identify these items is SINS. We look at the severity, the irritability, the nature, and the stage of the injury or illness. The severity of the injury is the degree or extent of structural damage. For example, we can have different grades of sprains and strains of different body parts When we look at an ankle, we can have a grade 1 sprain. When we look at a grade 1 sprain, it's just mild signs and symptoms, and it's not that traumatic of an injury. When we look at a grade 3 injury, these are very severe injuries, and there's an increased possibility that we need to refer an athlete based off this degree or based off these signs and symptoms. Next is irritability. Irritability is determined by what the athlete tells you in regard to his or her symptoms. The extent of pain and the actual injury determine the injury's irritability. Now, in this situation, we need to determine what that athlete's pain is. So we may ask them to describe their pain. They may describe pain as sharp, dull, burning, aching, stinging. There's a lot of descriptors that people can use to describe pain. The description of their pain can lead us to determine the type of injury. For example, if it is a sharp type of pain, they may have a fracture. If it's a dull type of injury or dull type of pain, they may have a chronic type of muscle strain in their body. We can also utilize a pain scale to determine what level of pain that they're at. They could be at a 0, which means no pain, and we can ask them 0 to 10, 10 being the worst imaginable pain, that they can assess where their pain is on that scale. Within this pain irritability area, we need to determine what really is going on that's causing the pain. Does it hurt when they walk? Does it hurt when they're walking stairs? But we need to know what's really bothering them and what's irritating them from that injury. Regardless of the athlete's pain tolerance, the higher the athlete's pain scale rating, the more irritable the athlete's injury or illness is for that person. Next, we look at nature of the injury or illness. The nature of the injury or illness is a description of the injury or illness that has afflicted the athlete. This usually involves where the injury is. So what description, what structure is actually damaged, which helps us classify that injury. Lastly, we'll look at the stage of the injury. The stage of the injury is described by 3 common injury classifications. These 3 include acute, subacute, and chronic types of injuries. At the acute injury stage, these are caused by a traumatic event. These result in sudden inflammation to the injured area, and the signs and symptoms of acute injuries last from about a week to as long as a month. After the acute stage, the injury may move into the subacute stage. The subacute stage is when an athlete has an injury that's been afflicting them for a month or a little bit over a month. Now, when we look at subacute injuries, they still may have symptoms of inflammation, but they have significantly decreased symptoms of inflammation, even though there's still some. But this is compared to the acute phase when their symptoms are greater. They also may be bothered by the injury still. Lastly, we have the chronic stage, and the chronic stage includes injuries that typically have a long onset. The athlete is not able to participate in activity at his or her desired level for many months due to the signs and symptoms that accompany the injury. These types of injuries require intervention and rehabilitation and takes an atypical amount of time to heal. Next, we will move on to the HOPS system. The HOPS system, and there's many other systems other than HOPS, but HOPS is very easy to remember because of the acronym. And we use the HOPS system, our history, observation, palpation, and special tests, which is included in HOPS, H-O-P-S, to really identify the specific injury or illness so that we can provide the proper care or referral for that athlete. Our first step in this process is history, or the H. The history helps us determine the athlete's perspective of the injury. So in this stage, we want to gain the athlete's subjective point of view and information regarding the injury from their personal experience. In this stage, we look at asking the athlete open-ended questions to allow the athlete to fully describe their condition in detail. We want to really try to avoid yes and no types of questions. These are very easy for the athlete to answer and not be very descriptive or be very lackadaisical in their answers and just give you an answer to move on without being detailed and what's going on with their injury. Really what we want to do with these open-ended questions is look at what has caused the injury. So we're looking at the mechanism of injury, how the injury occurred, and ask them really what happened. So they're really telling us a story, and we want to try to encourage that athlete to talk freely, share their experience through this injury, so that we know from their point of view what is going on. These are some history questions that you'll see in the textbook. Some questions ask what happened, when did the injury occur, what type of pain are you having. So very open-ended questions that they have to be more detailed in the responses other than yes or no. The second stage of the HOPS process is observation. Now, as we get into the observation stage, we are still overlapping the stage with the history stage. When we look at observation, we are looking at really from our perspective. What do we see, our objective inspection of the injury? As we observe the injury, we are still asking the athlete questions about what happened. And likewise, I didn't mention on the last slide, but as we're asking the athlete questions, we are observing their mannerisms, and we're also observing the injury as well when we're asking questions in the history phase. The observation looks really at identifying the irrefutable signs of the injury. So really, what do we see? Not necessarily symptoms. The symptoms, remember, are provided by the athlete, so we'll get that in the history. But we're looking at these signs that they can't hide, that we can see with our eyes that's occurring with the athlete. By also observing the injury, we can also look at body language and facial expressions, so we can determine what kind of emotions are attached to this injury. And we always want to make sure that we're observing the athlete bilaterally so we can compare. So we're looking at both sides to compare the injured body part side to the uninjured side. These are typical things that we look at that are observable signs of injury. So you can read over that list. It's also included in your textbook. The third step is palpation. Palpation or touching is really determining where the injured tissues are and if there's any malalignment or anything that we can feel that's going on, such as a knot, maybe something out of place in that injured body part. So before we even think about touching somebody or palpating somebody, we need to ask the athlete if they are allow us to touch them and the surrounding tissues, as well as not just the injured side, but the contralateral or the opposite side, so that we can continue to compare uninjured and injured side to each other. So in order for palpation to evolve, we want to start with the uninjured side first. We want to let the athlete know what it is to be expected and how we will palpate the injured area. And we want to make sure that by palpating the contralateral side, that they're trusting us in what we're doing. And this also helps us determine what is normal or baseline for the athlete's injured side, as well as help us determine the injured structures by comparing the injured side after the uninjured side via this use of palpation. So the big part is with palpation, you need to pull back all that knowledge from functional anatomy, knowing where our structures are, knowing what is normal, knowing where their locations are, so that we can distinguish what is normal, what is abnormal anatomically, and then compare it bilaterally what is normal, what is abnormal for that athlete. Included in this is bony and soft tissue. We have to make sure that we do this in a systematic manner on both sides, so that as we palpate the contralateral side, the uninjured side, we're going to do the same process on the injured side, so that we can really compare what's going on the injured side. These are principles of palpation, so make sure that you review those, but I've kind of pared it down a little bit. These are things to keep in mind while palpating. Know what you're palpating, so know your anatomy. Use an organized approach. Begin with light touch, and then if they're okay with that, gradually increase your pressure to look at underlying structures. Always obtain permission. Always be discreet. Make sure that you take the athlete's consideration into account, and give an explanation of what you're doing, so they still are trusting you. Lastly, we have special tests. Special tests are various procedures that we use really to rule out or confirm what we have already found in our history, our observation, and our palpation aspect. In athletic training, throughout these first 3 steps, we should really know what the injury is. And special tests, like I said, they're really used to confirm and rule out other potential injuries. So when we look at this process, this last process, we should have 1, 2, or maybe 3 injuries that we think it is, and we're using special tests to rule out the other ones and really define what's going on. So the first part of this is range of motion assessment. When we look at range of motion, we have different types. Active range of motion is the range of motion around a joint that the athlete creates by contracting his or her muscle voluntarily. When we see this, if there's pain as they're going through active range of motion, this typically indicates that they're having some sort of muscular injury, because as the muscle contracts, they're having this pain. For passive range of motion, when we use passive range of motion, we as the evaluator are putting them through this range of motion passively or without muscle contraction. When we look at this and they're having pain, these are injuries typically related to structures that don't contract, such as ligaments. So if we're passively moving the ankle and there's pain, it may be a ligamentous structure that is injured, compared to a muscular structure that would be painful with active range of motion. As we continue through this special test process, we have this idea of manual muscle test. Manual muscle test looks at the athlete performing an active range of motion while the evaluator is applying resistance, really determining the integrity of that muscle and the strength of that muscle. So it's really good to compare bilaterally to see if there's any strength deficits on the injured side compared to the uninjured side. In addition to this, all of our muscles are innervated by nerves, and if we have some decreased muscle strength or movement in that muscle when we're using manual muscle test, there may be something neurologically going on and we're not getting the activation of the nerves in that muscle correctly. Next, we'll move on to circulation, and circulation really looks at the evaluation of distal pulse to the injured area. So if we're looking at the ankle and we have an ankle injury, we could assess the dorsal pedal pulse, which is on the top of the foot. Or if we're looking at an injury to the upper extremity, we can use the radial pulse, which is by the wrist, and assess what circulation or what the beats per minute is from that standpoint. There's a really detailed explanation of how to take pulse in the book, but we'll talk about that in other classes in the kinesiology major if you have not already done so. In addition, we can also look for capillary bed refill. This is when we press on the nail and it turns white for a second, but as we release, that area, the bed of the nail, refills with blood. If that's pink or red again, then we have good circulation at the distal extremities at our fingers and toes. Next, respiration. We can look at the counting the total number of breaths per minute. Maybe they're going to shock, or maybe they're having an allergic reaction. We want to make sure that the respiration rate is within the normal respiration rate for an adult, which is about 20 breaths per minute, but it could go between 15 to 20 breaths per minute. Finishing up with special tests, we look at blood pressure. You can look at the detailed explanation of blood pressure in the textbook, but we can look at blood pressure to see if that person is going to shock or if they're having some other pressure-oriented or heart-oriented problems according to the injury. And lastly, we can look at neurological function, and it should be really evaluated if the athlete complains, if they're having signs and symptoms of tingling, numbness, or they're having strange sensations, oh, my right side doesn't feel the same as my left side, that we can look at neurological function. And I added some different things here, dermatomes versus myotomes. Dermatomes, if you ever see this word, it's not necessarily in the textbook, but dermatomes are nerves that innervate an area of skin. So if there's some sort of sensation difference between the sides, that's a dermatome, and all spinal roots have a dermatome attached to it. They also have a myotome attached to it, and myotomes are nerve roots that go to the specific muscle. So if there's an injury to the muscle and it affects the nerve, we'll see muscular weakness, and this is what is being affected, is what the myotome. Lastly, we can look at cranial nerve function in case they have a head injury or they have fallen and we don't know, or we may suspect that they have a head injury, but we'll get into more of that. But we can check the cranial nerves as well for neurological function.